Welcome to Genomics Gupshup. Genomics Gupshup is an initiative by Mapmygenome to create a community around genomics and to simplify genomics for everyone. And we do this by bringing together experts from allied areas like medicine, genetic counseling, nutrition, fitness, and more. Please join us as we spread this exciting science about genomics. We are now available on your favorite podcast, whether it's Apple Podcasts, Spotify, Google, or others. In this 36th episode, we are thrilled to welcome Dr. Daljeet Kaur, who is a UK trained psychiatrist with 17 years of experience and is one of the best psychiatrists in Hyderabad. Welcome to the show, Dr. Daljeet.
Thank you.
So, Dr. Daljeet, I want to understand, what were your motivations to become a psychiatrist?
Yeah, it's very interesting actually. When I finished my MBBS, because I did my MBBS from India, you get very little experience of psychiatry, hardly 2 weeks in your internship. And what you get to see is some really psychotic, unwell patients, very shabby and untreated, that just puts you off psychiatry because that's what you're seeing in those 2 weeks. And it can be very disheartening. It can actually affect people emotionally as well to be seeing so unwell patients. So my experience of psychiatry in India was not something that would have helped me decide it as a career. Actually, I wanted to be a pediatrician. But what happened is I finished my MBBS, I got married, and then I moved to the UK. And over in UK, after your qualifying exams, you're expected to do an attachment with someone to get into the system in NHS. And it just so happened that, we knew someone who was into psychiatry, through a family friend and all. And then I started working there. And wow, it was a whole different world. I mean, the kind of patients I saw, the kind of doctors I saw, the kind of care, the community system, the inpatient care, everything seemed so different. It just didn't seem like psychiatry, it just seemed like any other medical field. And there were so many regulations in place. People were not that unwell. If someone was unwell, they were taken to the hospital. There were laws in place. So I actually did 9 months as attachment in psychiatry, which means I took up all that time to decide whether I wanted to do psychiatry or not. And the care and everything, I mean, it was really impressive for me. I somehow got really fascinated just being able to relate to people, connect to them, do something for them and see them improve. It was like wonderful and rewarding. So then, I obviously did attachments in other specialties as well, medicine and other specialties, to see if I wanted to pick them up. But then finally my choice was psychiatry. I'm really proud to have chosen psychiatry. I really enjoy my work, whether I work in India or UK. That's clinical part is the best thing for me.
Yeah, I think, a lot of times we didn't understand how much of, it's the brain can be so difficult sometimes, and for all of us, I guess, at some point, right? I remember when we were doing some research, they said 1 out of 4 people are likely to have some sort of a mental health problem, right?
That's right, yeah.
So I think, there was so much taboo around this whole subject of psychiatry, I think, that not from a doctor's perspective, but more from a patient's perspective. But I think maybe, do you think that it has been normalized now to some extent? Or?
I wouldn't say it's normalized, definitely not. There's a lot of scope, for improvement there. But I think the stigma has reduced a little bit. And what has helped is obviously, a lot of celebrities coming out and talking about their illnesses, about bipolar, about depression and so on. Plus with COVID, as you know, everyone was, stuck in the same situation. Most of them had to go through some or the other emotional problems or mental health problems. People got so anxious, just, the fear of acquiring COVID. So anxiety is somewhere normalized now, I would say. People would not feel ashamed or so coming seeking help for anxiety, because you could be anxious, worrying about getting COVID. You could be anxious about going to a hospital. So palpitations, anxiety, those are kind of, being normalized now, and physicians are also open to it. Referrals are coming to psychiatrists as well. So I think people are more aware now, definitely, and they are seeking help.
And you think that on that topic of that we have at least normalized to some extent anxiety and maybe depression, but I think depression sometimes is used in the wrong context as well, right? Like, I mean, we say, oh, I'm very depressed, right? And I think that doesn't necessarily mean clinical depression in some form.
True. Right. So I do see, quite a few teenagers as well, because I'm into adolescent psychiatry and general adults. So, as you said, kids even from school, would just so casually use the word depression. So there are different kinds of depression. Obviously, the clinical depression is that what we need to worry most. But people can have depressive symptoms following a stressor in their life, a significant life event or so, which we call as adjustment disorder. And because there is a stress attached to it, there is a trigger to it, it's much easier for us to focus on that and get it treated. Obviously, the medication helps, but also counseling kind of helps a lot. So adjustment disorder is different from clinical depression. Just feeling sad is again not depression. We are allowed to feel sad if something doesn't. If something doesn't go right in our life, so we should not start generalizing and use these phrases depression to the extent we are.
And do you think that, I have a teenage daughter as well and an older one also, but do you think that the mobile phone has sort of created some of these mental health challenges that we see today, or they don't even, they're pretty much stuck to their phones? Do you think that we'll see even more problems in the future with generations being that addicted to their phones?
Well, we don't know. Obviously, things in the past haven't helped much. Everyone was stuck, due to COVID within the houses, and then they were depending a lot on their digital stuff. I mean, gadgets somewhere helped people when they were alone. It really helped them, cope with the loneliness. So in a way, it's been positive. Obviously, it's a different topic altogether. Adolescents are getting quite addicted to mobiles, and there will have to be some strategies put in place. There's going to be some parental education on it, and the child themselves having to work through, what is the reason for them to be so addicted? Is it because they don't want to socialize? Is it because they're anxious? Is it just that they are bored? And so on. There are various things that need to be looked into.
Or the dopamine rush.
Of course, everyone likes, the rewards you get in your brain, definitely.
And you mentioned that COVID-19 has obviously made it worse. So how do people know when they should come and see you? What are the signs that they look out for, other than feeling sad and maybe not having access to their phones? How do people normally reach out to a psychiatrist? Do they know, or is it usually the family member who finds out? Or how do they, let's assume they haven't done a genetic test yet also.
Yeah, I mean, not everyone directly comes to a psychiatrist, and it's also not necessary for them to do that directly. I think if someone's feeling sad, there's been a reason to it, be it a bereavement or a breakup or things like that, they can always go to a counselor. And obviously, if you've got good family support, that's the first thing to use. You might have very good friends, but again, there's a boundary you need to put as to how much, capable they feel to help you, because you don't want them to, feel overwhelmed. So you can go to a counselor, and things might stop just there. So you don't necessarily need to see a psychiatrist. But if you start having symptoms, we go into the psychopathology and all, there are different symptoms for depression, different ones for anxiety, different ones for, psychosis. If you have symptoms going on in your life for over 2 weeks or a month or so, which is affecting your day-to-day functioning to the point that you're not sleeping well, you're not eating well, you're losing interest, you're not enjoying yourself or others' company, then definitely yes, you would not want to delay things. It is always worth seeing a professional, whether you want to see a clinical psychologist, whether you want to see a psychiatrist, but that would be the right time. When you feel, you're not able to focus at work or your health is being affected, that's the right time to go see a professional.
And the difference between a clinical psychologist versus a psychiatrist from a, how would you differentiate both? You said you can go to either one, right?
Yes. So you got counselors who would have probably done bachelor's or master's in psychology, and they would be able to help you with the basic needs like supportive counseling or CBT and so on. Then you would have clinical psychologists who would have either done an MPhil or PhD in specific part or a diploma or so. And they are not doctors, but they can definitely go a little bit deeper into the psychopathology of the conditions, mental health conditions. They can write reports, they can do assessments for various conditions as well. But then when you talk about psychiatrist, it is obviously an MBBS doctor who then specializes into psychiatry, and then they can again choose a super specialty if they want to. So if it's got anything to do with the medication or a comprehensive assessment and diagnosis, then the first step is to go into a psychiatrist.
So typical kinds of condition a psychiatrist would see would be schizophrenia, bipolar,
yes, so
depression.
It depends on it depends where you are exactly, because when I was in the UK, the way the care services are put in there, it's different. So if you are into primary care service, then it's mainly the general physician and the counseling services who would look into the basic kinds like depression, anxiety, adjustment disorders, and so on. So normally you wouldn't have a psychiatrist seeing someone with depression or so. Psychiatrist comes under secondary care services. So you would have someone who's got refractory depression or bipolar or schizophrenia and bit more serious conditions. But in India, we don't have this system of primary care or secondary care. Obviously, you have tertiary care hospitals for various things like transplants and all. But from a psychiatry point of view, since I've been associated with corporate hospitals and also doing my own private work, you tend to see these things like depression, anxiety, psychosomatic problems, postnatal depression, postnatal psychosis, and so on. So we end up seeing most of the conditions.
So you become you are a combination of
a general physician and a psychiatrist. Yeah.
And do you see that typically like they're running in families, or do you find a lot of especially because some of these conditions are heritable. So do you often find that when you have one patient, you pretty much have siblings and other this thing, or is it that mostly you are seeing as one-off cases?
So depends. I mean, obviously some conditions are heritable within the mental health, but if someone's coming to me, most of the time the family members wouldn't want to go to the same doctor, for their own confidentiality, and there can be complicated dynamics within the family.
I didn't think about that, yeah.
But yes, if someone has a family history of mental health conditions, then you are a little bit, obviously predisposed. And but when we talk about mental health conditions, it's not just biological part we are looking into. Because in psychiatry, we look into the biopsychosocial model. So although you might have a certain predisposition, genetic predisposition, but depends on what's happening in your life, the environmental factors, the social factors. So suppose there are two people with the same predisposition, but one has good social support and has had a good life, and things are working fine for them, they might actually not end up presenting with that disease, whereas the other person, if things didn't go well, socially deprived and so on, any social deficits, then they are more likely to be presenting with symptoms. So it's a little bit tricky, it's not very straightforward.
Actually, so one of the things I remember when we first started, we worked with a company in the US called Total Brain. And there we had an app and also we had a report called Web Neuro. So there we would be able to do a set of questions online. And then we would do an assessment in terms of whether you currently have like an ADHD, or even some of the other illnesses. Then we realized that if you want to do that, then it becomes hard, because there is obviously for some people there is a predisposition genetically, but there is also for some people the manifestation at that time. So what we did was then combine the two. We said, can we put a combined play where we say that there are risk factors that come from your genetics, there are risk factors that come from what you mentioned, the social deficits in the system. But I think there are also other stress, like things like sleep and exercise and others that also play a role in some of these conditions as well, right?
Yes, definitely. I mean, obviously, the psychiatry part obviously it shares and has a lot of comorbidities with the physical health conditions. So, managing a good lifestyle and making all the lifestyle changes that definitely applies, just like any other issues.
Yeah, I know a lot of people who started doing a lot of serious physical activity and a lot of their symptoms actually reduced, right? So whether you take on running as a habit, as an activity or something else, I think there is a change in some of your.
Yes, so when we talk about neurochemicals, obviously in case of depression, we're talking about the serotonin, the levels are low and we need to increase or we need to save whatever serotonin we've got. So when we use medication, we're using SSRIs, which are selective reuptake inhibitors. So same way, if we want to more serotonin in our brain, things like there's enough evidence to suggest exercise, jogging, running, these also release the serotonin in your brain with physical activity. And I think that's what, in a general term, we call them happy hormones. The happy hormones are released and therefore you feel slightly better after exercise.
Yeah. I think a lot of people don't seem to understand that it has a major effect on, on their mental health, but I think that's I wanted you to
yes, it's got a
so,
biological explanation
yes.
as well, yes.
And also there are lots of since we are on the topic of serotonin, I think there are a lot of medications that are like the SSRIs and others, but some of there are many patients who will probably not respond well to them and many who do. So do you think that with using a product like a Medicamap or something, do you think that there is a possibility of reducing the time it takes to sort of help the patients in a better medication if that is there? Or?
I think definitely it can be a good support or addition to the clinical management. I've read about Medicamap and I've kind of seen the report, and also definitely because if someone comes to me with depressive symptoms, it's a very crucial time for them. For example, I just saw someone the other day. I've started a student on SSRI, and then she's emailed me saying I'm feeling quite restless and feeling very uncomfortable. Although I started her on a very small dose, so I did not expect those kind of serotonergic kind of side effects to her, and I was surprised. And she was like, "Oh, I'm having my exams very soon. What should I do?" So situations like this, where if I had a chance just to assess in the beginning itself which medication would suit this person, because pharmacogenomics is a very important topic. So a certain individual of a certain ethnic background might be metabolizing a certain medication in a different way, and suppose this person only needs a 10 milligram of the medication and my starting dose is 20. I have no idea that this person is a slow metabolizer. Yeah, so if I did something like a Medicamap and it gives me an kind of advice or some suggestions that this is likely to happen, then I'm going to be saving those initial 2-3 weeks for this client. Yeah, so they don't have to go through all these unpleasant side effects, and the symptom response is also going to be good. I can smoothly kind of optimize the medication, or if I know this medication is not going to suit, because in psychiatry what we do is we don't like just start a medication and stop it after a week or so. We do give it at least 2 to 3 weeks to see a minimal effect, and 6 weeks to see a good effect. So if I'm going to be wasting 5 to 6 weeks for a patient just trying out a medication, and if I have something suggesting, well, this is a better one than the other, I would definitely like to try that.
Absolutely, because I remember once, this for 10, 12 years ago, where one of the US pharmacies said that 1/3 of their sales came from antidepressants. But they also added with that 1/3 of them quickly stopped because I think it's probably not working for them, right? So I think, of course, I don't think that's true in India. I don't think a large part of our sales are antidepressants, but I may be wrong. You probably know better. But I think if it is not effective, I think, and more importantly, giving you the wrong adverse effects, I think it becomes a challenge. So when, let's say they do there are genetic markers that are associated with sometimes high risk of schizophrenia, high risk of depression and others. If the patients find out, do you think if they know that like a family history is there and they started to feel that initial symptoms or whatever, how do they take that news? Do they realize that it's in the family and therefore an eventuality, or is it more like, they're just hoping for the best in that? Or is it case by case?
I mean, it's a very anxiety-provoking situation, isn't it? When you already know that one of your family member has had a severe and enduring illness like schizophrenia or bipolar, and you also know that there are chances of heritability. Would you want to do a genetic test to know whether you have it or not? I think as a clinician, I would want to know how is that going to benefit my patient, because I do know there is a risk. And in psychiatry, most of the time, it's a clinical judgment in terms of their symptomatology, and also, as I told you, what's happening in their life at that particular point of time. So, although I strongly believe in early intervention of symptoms and of the presentation, what I would do is anyone with family risk, probably I would want them to come and see me, for follow-up or just for an assessment, so we can put down a plan. I'm not sure if I would use genetic testing for diagnosis, because I don't think it's going to help that much in terms of clinical management, but I am quite keen on using the pharmacogenomic part of it, where I can kind of help them with the treatment part. So there's a lot of genetic overlap, with various neurological conditions, with various physical health conditions. So from my own clinical practice, if I was to look, I think just a couple of weeks ago, I've seen a child for an assessment of ADHD, and they had come with testing done, and the child had Duchenne muscular dystrophy. So obviously the way I'm going to manage this child is going to be different. When I was in the UK, I had seen a person really anxious who had a family history of Huntington's chorea. And we know that the mental health problems are quite, strongly associated. So somewhere where maybe the medical part can be looked into, suppose this person has a diagnosis, or has had an assessment for Huntington's and all, and if that can put him to ease, and we can help him with his mental health conditions, I think that I would look into. That would be quite supportive. Alzheimer's, people come asking us about questions, my family has Alzheimer's, will I be getting it and all. So in some conditions, I think if they get to know that they have that predisposition, they are likely, probably it will help them decide for their future. But most of the times, it is only going to raise anxieties.
Of course, I don't necessarily fully subscribe to that, but that's, I think, because one of the things we found is that, I know a lot of, we get, there's some percentage of people who say, I want to understand about my fitness, nutrition and all that. I don't want to know about Alzheimer's. Right? There is a small set of people who will be like, I don't want to know. Right? I mean, if I have like an APOE4 mutation and all of that. But on the other hand, there are some people who are like, I want to know because I want to rule out that condition. Similarly, for the breast cancer patient, I think we find that some people with the family history also don't want to find out, even though they're constantly worrying about whether I'll get it or not. Right? So I think you are better off doing it to find out, to rule out the chances of your anxiety going lower or higher, if you find out that you're negative, for instance. Right? But I think, I guess that's why.
So I think it's very case to case, obviously in some situations maybe it helps, in other situations it might just make the situation worse depending on, the other things going on in this person's life.
Yeah, I think the more important thing is to explain to people that, even if you have it, that this is one of the risk factors. It is not the only thing, right? I mean, and the sooner we know, the more you can do about it. I guess in some cases, like Alzheimer's, I think there's some things you can do, and I think just recently a new drug has just been, showing good clinical signs as well. So hopefully, I think over the next few years, we'll see that there are more drugs and more treatment options for some of these people who probably think that maybe this is not something that they can do anything about.
Yeah, because the way we would manage Alzheimer's, since I've worked at memory clinics in the UK as well, if someone's got mild cognitive impairment, you're not going to start them on medication immediately. You're going to be looking at other environmental, adjustments and things like that. So what mostly happens is it's a lot of, kind of cognitive assessments and structural imaging and all that kind of aids the diagnosis. Yes, as I said, this can be a supportive one, and suppose it's done along with a general, genomic testing, it might be of advantage. And again, it depends entirely about the client, whether they want it to be done, because they should be included in the decision making as well.
So I think that's why we said, for the people who don't want to know, we said we'll introduce Medicamap. Because I think in the end, if people are in general, I think healthy, right? They maintain a lot in terms of, they're eating the right things based on their genes. They're being fit. I think in many ways they're also impacting other parts of their potential missing, whether it's diabetes, whether it's mental health or otherwise. So I'm okay. I think there are people of different kinds. We find people who want to know everything today. There are people who are like, let me think about it, and then.
Yeah. I mean, I think these things should be, offered to people, and they should be counseled. They should be given the information.
Exactly.
Obviously, as you said, some people might be very keen and inquisitive, so it should be on the offer. And from what I understand, it's quite affordable as well. So definitely, it might help lots of people if they want to take it on. But the initial, counseling has to be done as to, suppose this comes as a diagnosis, how do you manage it, all that, especially for someone who's already got mental health issues. I think that's a very important part, that, pre-counseling part has to be done.
No, I agree. I think the counseling piece is the most important. So if you had to, and mental health is obviously a very big, broad area of this thing. Experience, but if you had to define prevention, how would you define prevention?
In terms of mental health?
Mental health, preferably.
Okay. I think first part is going to be awareness, creating awareness of mental health conditions, because unless you know what you're going to look for or what you're likely to be, presenting, whether it's the family part, the heritability part, that awareness needs to be there, the way conditions present, that needs to be there. Once the awareness is done, obviously, since psychiatry is not just about the biological, the lifestyle changes that would be there. If there is already a risk identified for developing a condition, then regular contacts with the professionals. That needs to be done. All the comorbidities, whether it is cardiovascular or neurological, everything needs to be, in place. So overall, I think a holistic approach needs to be taken. So if you are happy, if you are healthy as a person, I think then everything kind of follows. And where we start, obviously after prevention, I think even if there's the slightest of the symptom, then you're looking at early intervention. So that has to collaborate with the prevention part.
So I want to ask you one interesting thing. They say that a lot of things depends. If you think about it in your mind, then it also has an effect on your body, right? So you think happy thoughts, it is going to percolate in your. Mm-hmm. So is that one? Is that true? And two is how do you force someone to think happy thoughts? Right? Like, see, someone like me, I think in general, I think I'm quite a positive person, right? But how do you force, let's say, somebody who's maybe not in that space of mind? How do you get them to start thinking about happy thoughts? Yeah.
So first of all, you can't force anyone to feel happy. I think you are talking about the basic, model of CBT, cognitive behavioral therapy. So yes, cognition, that is your thought. Yes. So the thought process is very important, because it all depends on how you think. If you think in a certain way, then your behavior is going to be according to that. So if I'm having negative thoughts, suppose, I'm feeling really anxious coming here, and I'm like, oh my God, I'm going to spoil this interview, or I'm going to mess up or so, then the way I behave would be either I'm going to avoid coming here, or when I'm here, I'm going to be really nervous, fidgety, and I'm going to be really distracted. And then, so that affects my behavior and the way I'm going to feel, the emotional part. Either I could either be frustrated, I could be anxious, I could be feeling sad, oh my God, I messed it up. Yeah. But suppose I had that negative thought while I'm going for an interview or I'm going for a talk, it might not go that great or whatever, And then I'm like, okay, that's fine. So I've got that spontaneous thought. But what I'm going to think now is, what are the chances of that happening? Or even if it does, what is the worst that can happen? Okay, it might not go that great, but it will be fine. So once I change my thinking to a bit more positive thought, I'm going to then feel less anxious, less frustrated. I'm going to be more casual, and behavior wise, I'm just going to be very, relaxed. And I will be like, okay, I know I'll come and meet you again next. Let's do this, that. So I think there are different kind of therapies, there are different approaches that can be taken where you can, your thought process can be changed. A lot of it can be done by yourself. There are a lot of self-help books and videos, and also you can inculcate that positive self-talk, and you will then start feeling better. So obviously, just thinking I want to feel happy is not going to make me feel happy. all these things kind of go on, and if you do not know that by yourself, obviously a professional, either a psychologist, counselor, someone can teach you those ways of converting your negative thoughts to a bit more happier thoughts, or anxious thoughts to a bit more relaxed thoughts. So yes, definitely that's what mental health services are about.
So I remember also this other book, I don't know if you've read it, The Gene. And so this is the book by Dr. Siddharth Mukherjee, and one of the things he starts off with is actually about schizophrenia and how it is running in the family and all of that. Is that and that's obviously not an easy thing to manage, but if people come in early, are they able to take care of them better? And I also remember once, we were getting desperate calls from someone because I think schizophrenia was listed as one of the things that is there in our report. We were getting calls from some small town in India where they were very anxious about this thing. They wanted to understand it better. So how do you think that it is a heritable?
Yes, it is definitely. There are a few mental health conditions that are quite heritable. Autism spectrum disorder, schizophrenia, bipolar. Now, it is a very tricky question. The reason being, we have to, as professionals, take a very holistic approach. Now, for someone seeking a diagnosis of Alzheimer's, probably, even if they got to know they have Alzheimer's or there is a predisposition, the society is going to be positive about it. Family is going to support them. They know there is that medication available, or they're going to do their legal arrangements or whatever. So it is much more socially acceptable having that diagnosis of Alzheimer's. But if you got if you got someone looking for a diagnosis of schizophrenia, which I think most of the times it's the family looking for the diagnosis rather than the client themselves, what is the client going to benefit out of that? The kind of stigma and discrimination, especially if you're looking for the services in India. We do not have that kind of regulated services, either community services or inpatient, yes, but community services or support for someone who's been diagnosed with schizophrenia or discharged. So most of the care goes on to the family. Yeah. So if you told someone 10 years earlier or 5 years earlier that this patient is going to have schizophrenia, now I want you to just imagine what can go on in the minds of people. If this person comes to a psychiatrist with symptoms, it is not something that will be missed, because the symptoms are going to be quite, specific or classical. So a clinical diagnosis for schizophrenia can be easily made by the psychiatrist. So we have to think again, is this person going to have social deficits because of this diagnosis of schizophrenia? Or you got a fantastic family settled in US or so who wants to have this diagnosis and avail some other services, take them there. So I think it's a very individual and personalized decision a professional will have to take.
So my question was more that if somebody presented symptoms early, and let's say the family caught it, or whatever, because you said family mostly finds it.
Yeah.
I was just asking whether the treatment options are better when they find out early versus late, more than.
I think it's more of the early intervention work where the services and the role of psychiatrist and medication is going to be there. How it would actually make a difference, I'm not sure.
So it doesn't make that much
Yeah, it's not, because there are a lot of early intervention teams for psychosis and schizophrenia where they pick up the symptoms, and when you put a lot of support along with medication, the recovery is much faster.
So we were talking about Alzheimer's. What is the secret to healthy aging in your view?
Healthy aging, I guess, there's so much in the market. People talk about antioxidants, other products, cod liver oil, so many things. I would just say good physical activity, lifestyle changes. If you have any comorbidities like diabetes, hypertension, any issues, either, your cholesterol's high, hyperlipidemia, whatever, if those things are in control, if you are able to monitor that and control that, I think you are automatically reducing the risk factors, because all these are risk factors, for Alzheimer's, along with age, rest of the things. Good, if you're physically active, you're going to protect your heart and lots of things. So once you develop Alzheimer's, really there's not much you can do because it's progressive illness. So whatever you can in terms of prevention, definitely, it is worth looking at. But there's no specific medication or something that you can use so you do not get, Alzheimer's. It is about controlling all these. So if you have diabetes and, your sugars are 320, 500 and you're like, oh, it's okay, chalta hai, if you carry that kind of attitude, that's not going to help.
And I think you said the right thing, that there are mostly, I think we can do a lot of lifestyle intervention. They are more likely to give you some sort of a positive effect than something.
Definitely. And also if you can incorporate yoga, meditation, relaxation, all these, because your mind is going to feel relaxed, you're going to have a healthy body, and then definitely that will have an impact on your cognition, definitely.
And do you think a lot of studies have shown that when you do meditation and yoga and all of this, that you can actually start seeing that in terms of methylation and other epigenetic markers on the genome itself? Do you think there will be people interested in knowing if their epigenetics is showing signs of stress or others? So this is not like genetic, but it's more about what you've done to yourself, right?
Yeah.
We have just launched the microbiome, which is more understanding of the gut microbiome, but we are looking at epigenetics. But do you think that people would be keen on knowing, if some, because earlier when you said genetics, it was basically saying either I blame my parents because they gave me these genes, or you said fine, this is what it is, it's my destiny, or you've used it for your benefit, you've been able to make some changes. For the people who made some changes, is there a validation in getting something like that, which say that today your biological age is 70, and then if you do blah blah blah, then you will be able to become 65 or
I mean, I think there's definitely a scope for that. People are going to invest in themselves, and if there is a validation that what they are doing is right and is giving some positive outcome, I think they're definitely going to be looking forward for it. So yes.
I guess I'm already going beyond our planned time, but we have a rapid fire round for sure.
Okay.
But one thing I think, and especially I think this must be even more true in psychiatry, is there must be a lot of myths. So can you give me some example of myths that obviously are not true?
Okay. So depends. I mean, obviously, since we're talking about pharmacogenomics and all, I think there's a very strong myth that once you start any psychiatric medication, you can't stop it. And that's not true. I think what's happened is a certain class of medication called benzodiazepine that's been very widely used by people in the past. If you got anyone struggling, if they're anxious or aggressive or whatever, there's been, big doses of benzodiazepines used and people never stopped it. So what happened is then people got addicted to it, and that's created a notion that yes, if you're on psychiatric medication, either you're zoned out, you're sleeping, you're over sedated, or they're addictive and you can't stop. So let me explain to you that's not the case. The variety of medication, and there is only certain degree of or certain class of medication that are addictive. Yes, there are few of those, but most of the psychiatrists now, what we use for general conditions, whether it is bipolar, whether it is depression, anxiety, or even schizophrenia, they're not the addictive kind of medication. They are there to treat you. Yes, some might have bit more side effects than other, but obviously there's clinical judgment, and now you got something, obviously in terms of genetic testing as well, where it's going to support us to tell us which one is probably more ideal for you. So I think that makes the treatment even more easy. So if you are struggling with your mental health and it's come to a point where you need medication, please do not stop yourself. And this is applying to all, even educated, people, sometimes even proper professionals as well, carrying on this thing. They come, they talk everything, and as soon as you mention about medication, they're like, oh no, can I try without medication? So let's break that myth about medication. Medication is really effective. You can take it as long as it is required. Obviously, you don't need to end up taking it for years and years. So that would require you following up with your psychiatrist and having a proper treatment plan. That's what I would say.
I think that's a great thing, because a lot of people do think that is yes. Yeah. So the other thing is, there's clearly been a plethora of mental health apps that have come up. Mm-hmm. Do you think that people will find and a lot of information as well, right? I mean, mental health is now covered by Ayushman Bharat, I think, and also I think insurance companies are forced to sort of use to take mental health as something that they need to reimburse. Do you think that like digital health has a role in psychiatry, and or do you think that psychiatry being a very human emotion centric field, because a lot of it is dependent on how someone actually talks to you and understands you?
Yeah.
Or will it be AI robots that will get to that point? But it's an interesting thing, because there's clearly like taboo, but there is also something missing, right?
Yeah. I mean, in an ideal world, obviously, you would want to go see a doctor, or you want to see a professional, have face-to-face conversation. There's a lot of observation also included in psychiatry. So when I have a client, obviously, I'm going to look at their gestures, the way they are they agitated, are they feeling a bit like, tired, and also there's a lot of observation that goes into. So yes, ideal scenario would be where you can. But you're aware that around COVID time, teleconsultation has taken on such a big role, and it's actually saved people. You can just imagine the anxiety levels of people went really high. Mental health services became so accessible. A lot of apps came in, a lot of people started doing just telephonic consultations, video consultations, Zoom, and so on. So I think digital health actually has been a savior. And even I have, obviously, I work with the hospital, but I also have my private company where I mainly do teleconsultations, video consultations. And I have clients not only in India, even outside. And it could be just students from here who've gone abroad to study. So I can offer them that continuity of care because they are my own patients. So I think it is very important, to have that continuity. Whether you can see someone in person, excellent. If you can't, and especially if you are, in rural areas, again, we are already scarce of psychiatrists in India. So if we are able to offer that services and, help people with mental health issues, it is fantastic. There are a lot of apps that have come up. They've been really useful. I think they've kind of replaced some therapy sessions as well, but never mind, we have to think from a patient's perspective as well, more cost effective for them, and it's helped. I think there was something in the news or someone shared it on WhatsApp about the AI and, actually treating the mental health problems as well. So I don't know what's the way forward. I think we all have to just wait and watch.
Yeah, Yeah, it was actually someone, I saw something on Twitter as well, where they had this really human-like person, did a FaceTime call with that
Yeah,
person.
like a robot, yeah.
So I think it's an interesting time, and I think also maybe the number of psychiatrists available are not that high also, right? So I think if you had to scale up and plan for more people that have mental health problems, I think the combination of the two is probably
Yes, definitely.
going to help. And I think even for a psychiatrist, if you get some assessment, some tool for a patient, I think it's not a bad thing.
Yes, so I think there's a lot of scope, obviously, but it should not be something that's going to replace, the psychiatrist. Otherwise, we wouldn't be in jobs. But yes, an additional thing, definitely, it is going to work.
Okay, we are on to our last segment called Rapid Fire. So let's start with what is the most common complaint that your friends have about you?
About me? I hope not. Well, some of my good friends, they might say I might not call them that often. Probably that might be the only thing. Otherwise, I'm quite a social person. So, really, not many complaints.
That's great. Yeah. And if you were not a psychiatrist or a doctor, what would you have become?
I would have been a teacher. One of the silliest reason I used to give in my school days for being a teacher was because I used to be a class monitor, and I really liked writing on the blackboard with a chalk piece. That is what fascinated me at that time. But even if I was to think now, I think, because we have so much respect for our teachers and they play such an important role in forming our personalities, that would have been my second choice. Yeah.
And I think now you are sort of doing some teaching through.
Yeah, I love teaching.
Yeah. Also through social media. Right?
Yes, definitely. Yeah.
Okay. Is there something that you would like to do more of and something that you would like to do less of?
Is that to do with the professional part or
anything?
So there was a really interesting thing. There's this concept of vocational rehabilitation for mental health in the UK, and I've seen those services there. So what I tried to do in the last year is I did form a social initiative. So I have my Dawn Welfare Foundation, through which I started an initiative called Recovery Hub. It is an initiative to help people with mental health issues get back into jobs or start jobs for the first time, because for whatever reason, say the kind of clients we've had is a doctor who just developed, say, schizophrenia in their internship period. As early 20s is the time when these kind of conditions come. So she had to take a couple of years of break because of her illness, just understanding the illness, starting on medication, reaching to a point where she could start writing neat and all that. So these are the clients where, offering whatever support for them to go back, from the break they have taken, which includes occupational therapy, So there are lots of services that I don't want to kind of go too much into detail. But what I would now like to do is, through my foundation, take some initiatives of different kind, focused on mental health problems and help them in their recovery.
I think that's absolutely a noble thing to do. I think there is a big need for doing something like that. Yeah. Which is your favorite book or movie?
I'm a proper Bollywood person. I love dancing, I love watching movies, I love watching series. So it might sound very silly, but there's one of the nice program called Katha that's going on Sony Live, which is my favorite for now. But I do like watching, a bit intellectual stuff as well. So as a family, we watched, Rocket Boys and lots of things. So I think anything that can give you good knowledge and a bit of fun as well. So I'm open to all the kind of stuff. So
I don't know if you watched, but one of my favorite things to watch is these FBI behavioral things where they look at prisoners and they look at serial killers and all of that. I don't know if they're actually true based on like real psychiatric, but some of them are. Some of them were documentaries, and some of them are. You don't find those interesting, I guess.
No, because I already do that at my work. I mean, as part of my training, I work in forensic psychiatry as well. So we've been in proper prison areas where it's high secure units, medium secure units, and we've done assessments there. So we've had all that
So
excitement.
that's work for you.
Yes, so that's all work for me. So when I come home, it's more about
Yeah.
relaxation.
True. And for me, I think it's interesting because I don't do that normally. So for me,
Yes.
it is exciting.
Definitely, yeah.
So that's great. So I think thank you once again. And if there's anything else you'd like to tell our viewers at this point, that would be great. Otherwise, thank you very much for your time.
No, I mean it's been a real privilege being invited here. You're doing such wonderful work, and obviously genomics was not something that we studied that much. Yes, you would do it for your exams, but the clinical or the practical usage of that in clinical practice, that was not something we really did, whether it was UK or India. So I'm quite excited actually, about the new things that can be used up. As you've seen, I might have different opinion for the diagnostic part, but for the treatment part, definitely I'm very keen. So I would be looking at more and more kind of initiatives like this, where we can together do something for the betterment of people who are struggling with mental health issues. So thank you so much for having me here.
And last, since you brought up that you not talk much about genetics, I think one of the things we are doing now is to create some academic courses as well to be able to create awareness. So we did one with Avinida on pharmacogenomics, and hopefully we can do others. But I think it's also very helpful to be able to change some of the curriculum that is taught to students, medical students now, because it's so difficult to, for them to be in an age where it is so much part of your clinical practice, but still not something that is taught in depth, right? Like you mentioned. So
definitely, and if it's been presented in a bit exciting and fun-loving way, even better, because it can be very complicated, isn't it, the genomic part? So although you can have long courses, if you're having short courses or kind of online courses where it can be for an hour or two, a quick update, something even for established doctors as a continuous professional development, we can pick up those kind of modules and kind of work on it.
That's exactly what we are doing with the Avenida thing. But I think we'll try to create more content for that. And I think it's also very helpful when doctors like you, who are experts in your field, are also looking at these options and
definitely. I mean, it's worth brushing up, isn't it? Yes, we did it in our training and everything, but if you've not been using it for so long, you're not going to be remembering all the genes and cytochromes and everything, isn't it? So it's good to just brush it up. Yeah.
Great. Thank you once again, and it was an absolute honor and pleasure to be here.
Thanks. Same here.